no testing on the weekend and a possible delay in reporting to the public. But what story do these statistics really tell us? Often they are showing raw numbers and not by population size and city size or country size. Also, especially here in Japan, new categories have been created. Those found to be COVID-19 positive on board the Diamond Princess cruise ship or those tested at the airport have been given their own category. They are not added to the overall Japanese numbers. Based on these statistics, Japan, though, is faring extraordinarily well. Even Germany's most famous virologist, Professor Christian Drosten, speaks highly of the Japanese model. So all these evaluations, which country fares well throughout the pandemic, which does not, hinge on the analysis of data, of statistics. And policymaking is based on what statistics tell us. But how are these statistics really gathered? How's the data accumulated? And can the data be trusted? How do cases and numbers of deaths relate to the number of PCR tests performed? These are highly important questions, and we look forward to our distinguished speakers addressing some of these issues. Sophie will introduce the speakers to you in a second. I would just like to mention that while the speakers give their input statements, we welcome you to submit questions to them. Please submit your questions on the right side of the screen here on YouTube. Thank you. Sophie and I will try to address as many of the questions as possible in the Q&A section that follows the presentations and relay them to the speakers for you. Sophie, dozo.
Thank you, Barbara. So my name is Sophie Bunick, and I wish a warm welcome to all the listeners who join us today to attend this workshop. On behalf of the French Research Institute on Japan at the Maison Franco-Japonaise, I am extremely glad and honored to play the role of moderator next to Barbara Althus. Our first panelist will be Professor Kenji Shibuya. Professor Shibuya is the founding director of the newly established Institute for Population Health at King's College London. He is also serving as senior advisor to the Director General of the World Health Organization after having worked as Chief of Health Policy. Before joining King's College, he was professor and chair inside the Department of Global Health Policy, Graduate School of Medicine at Tokyo University. He also played a key role in setting the direction of the Japanese government's global health policy after the Hokkaido G8 summit in 2008. And he led the Lancet series on Japan published in 2011. From this uniquely informed position, he will give us fresh insight into COVID statistics in Japan. Our second panelist, Professor Ansgar Lose, will address the pandemic's related statistics published by Germany. Since 2005, he is director of the Department of Medicine at the University Medical Center, Hamburg-Eppendorf, and heading its Center for Internal Medicine. After receiving his PhD from the University of Marburg, he studied medicine and philosophy in various research centers in Göttingen, London, Boston, Gutenberg University Mainz, and the Weizmann Institute of Science in Israel, among others. A specialist of gastroenterology and infectious diseases with a focus on immunology, he has contributed to the edition of clinical and scientific journals, and he chairs the commission Infection and Society for the Hamburg Academy of Sciences in particular. Finally, Professor Paul-André Rosenthal will give us a presentation of French statistics related to the pandemics. Professor Rosenthal teaches modern history at the Paris Institute of Political Studies, Sciences Po. His works focus on the implementation of social, demographic, and health policies in 19th and 20th century Europe, while leading a team of specialists in these fields within the School for Advanced Studies in the Social Sciences, EHESS. He also directed a European Research Council Advanced Grant Program at the crossroads between social sciences and medicine. Among his latest publications are Population, the State, and National Grandeur, Demography as a Political Science in Modern France, and Silicosis, A World History, released by Johns Hopkins University Press, as well as articles in medical journals like Lancet Global Health. Professor Shibuya, the floor is yours.
Thanks, everyone. And KCMS, right? KCMS, right? Hello?
Yes, we
see.
We see you. We see it.
The slide is on the screen.
Yes.
Okay, so thank you. So let me give you my quick presentation about Japanese COVID response with respect to the comparison with other countries. So I'll just talk three things. One is what has made a difference so far across countries, and followed by Japan's response and the future direction quickly. So as you know, this is the cases, deaths per million population, and United States, United Kingdom. Now all the European countries more or less have a relatively high death rate compared to Japan, South Korea, Singapore, and New Zealand. In the middle, sorry, I didn't change to the English name, but Brazil, Colombia, they are also increased numbers. But there are a bunch of speculation why this kind of large discrepancy in terms of reported cases and deaths across countries. So let me give you some of the numbers from my collaborators at the University of Washington. Of course, there are many models, but good thing about their model is that they show both reported and estimated, and also number of testing capacity. This is South Korea, as you can see on the screen. So the blue line is the testing capacity per day, and orange line is reported cases, and the dotted line is estimated cases. So as you can see in South Korea from the beginning, number of tests exceeds reported cases. So I think they managed very quickly from the beginning by expanding and testing capacity very quickly. And the UK, this is where I'm living right now. They started, this is the social distancing measures by period. And as you know, 12th of March, Prime Minister Johnson said the UK would not adopt school closure or event cancellation. Instead, the UK was planning to let the people infected by natural infection to achieve herd immunity. But soon after that, Imperial College and many scientists criticized that approach. And then on the 23rd of March, UK implemented lockdown 23rd. But if you look at the cases and testing capacity in the UK, and again, this is the estimate, and the blue line is the number of tests, and orange line the reported cases. So UK, like Japan, initially it was very delayed in terms of testing capacity. As you can see, when the UK was discussing about herd immunity strategy, it was already in an explosive phase. And the UK really missed this opportunity to contain from the early stage. And when the UK implemented lockdown, there were almost 120,000 cases per day. So it was in the middle of explosion. So it was too late to contain. If they could have done very early, at least at the latest 4 weeks earlier, it could have prevented the catastrophe as we see today. So also the testing capacity was not that high from the beginning, as opposed to the case in South Korea. New York, the same thing. They implement the same time the lockdown type of social distancing measure as in the case of UK. And the New York is the same thing. So when they implement the lockdown, and they have daily cases of 120,000. Of course, this is reported, and this is testing capacity. So reported cases was low, but from the estimate, the New York was already in the explosive phase. Germany was kind of a successful case, and the testing capacity was well exceeded the reported cases, and estimate is not that high. So it was like in Germany and also South Korea. And from the beginning, they acted aggressively by expanding testing capacity. France is the kind of mixture of these two. So they implement kind of lockdown and lifting now. But from the beginning, the slightly delayed and testing capacity was expanded, but it was already in the explosive phase. So, when the lockdown was implemented, there were 70,000 cases. And not that tough as in the UK, London, or New York, but not that good compared to Germany or South Korea. So this is the trends in R number, effective reproduction rate. And this is estimated by Imperial College, but if the impact of lockdown is substantive. So if you look at, this is the date, and this is R number, and then implemented lockdown on the 23rd of March, and R dropped down below 1 very quickly. But if you look at the number of estimate, on the y-axis is the daily number of cases, slightly different from the previous estimate, which I just showed you, but almost in the range of 300,000, 400 when they implement lockdown. So it was in the explosion. So it was too late. This is the trends in R published by the Japanese government. So the blue line is the R number, fluctuated because of the data thing. But at the beginning, Japan managed very well to contain the exponential growth until mid-March. And this is the number of reported cases. This is probably thanks to the cluster control approach to contain aggressively on the by the local community. But the prerequisite for the cluster control approach success is A, the transmission is localized. B, they were not so, because they are focusing on severe cases, only severe cases, so they miss quite a few asymptomatic cases. It worked well when the transmission was not that high, and also local community was well organized. But it was too late when mid-March, particularly big cities. So there were increasing number of undetected community transmission, and also foreign travelers, and also Japanese people coming back from Europe were spreading it. So it was very difficult for the cluster control to contain these people. So by mid-March, Japan was already in the exponential growth phase. And as you know, Japan could have prevented further if they acted around here, mid-March. But because of the Olympics or decision on the 24th of March, it was delayed. But Japan was lucky. Right after that, Governor Koike and kind of the stay at home, not compulsory, are followed by state of emergency measure. Then, as you can see, the R number dropped substantially. So I was very surprised because Japan didn't implement a very stringent lockdown measure, but it did work according to this data, assuming this data is valid enough. But still, of course, the quality of R number depends on the reported cases, although the modeler will adjust for the undetected cases. But still, there seems to be a substantive effect of these relative voluntary stay-at-home kind of measure. And state of emergency kind of delayed a week, but I think there was supplementary effect on that. So as you can see, when these measures were implemented, the number of cases per day was 500 or something. Of course, this is reported. So if we could assume that there was a factor of 10 of estimated number, but still it's 5,000, much less than those observed in Europe or United States. So I would say the timing was perfect, or we could have done a little bit earlier if there was no decision about Olympics. But Japan was all fortunate to be able to avoid the explosion. So there's a bunch of studies from the UK and the US that if the lockdown was implemented earlier, they could have prevented death substantively. So this shows the importance of prompt action. So there seems to be a substantial variation in terms of COVID-19 response. So UK, United States particularly, there was an explosion and a collapse of healthcare due to delayed response. Germany and South Korea, they started testing capacity expansion and did isolation and social distancing nicely. So it is thanks to prompt response, they managed to contain, although they once they lift to the kind of social distancing, there will be a small wave come back, but they are managing very well. I didn't show the figures, but Brazil, Colombia, they implemented lockdown, but it is increasing even after that. So there seems to be some social aspect. It's not about the lockdown or not. It is about how people behave well on the ground. So lockdown is very powerful, but it may be affected by social norms, environment, and social disparity and some sort of incentives. So let me go through quickly about Japan's response and numbers. And this is the usual measures which many of the countries adopt depending on the phase, depending on the government decision. When there was a localized cluster, they need to start travel restriction and testing expansion, and as Japan did for cluster control approach. And when there was a exponential growth, they need to start major social distancing and travel restriction further, and of course aggressively expand the testing capacity. And then when there was a impact of lockdown or the social distancing measure, all of them were implemented and followed by control phase. Right now we are in this phase, but Japan somehow delayed in these measures highlighted in red. So travel restriction was delayed at the time of exponential growth in the mid-March, because eventually they implement travel restriction later, months later. And testing capacity was not expanded, as I said, and cluster approach was focusing primarily on severe cases, assuming that once you identify severe cases, they can track all the potential infected cases. But initially, they didn't test asymptomatic cases. That was why there was, many missing cases through cluster approach. They changed the policy to include those in terms of contact tracing. They tried to test now the asymptomatic contact, which is a good change. But still, they're focusing on cluster control approach. So there are pros and cons on that. So, but the important thing is the mixture of all of this will be important, particularly in the control phase. Expanding testing capacity to identify the early cases, and of course, preparation for the next wave for the healthcare will be crucial. So Japanese model, there are a bunch of speculation anecdotes, like Dr. Omi mentioned, he's a vice chair of the expert panel. He said 3 things. One is universal access to high quality care to identify severe cases, and cluster control approach, and people's attitudes of good hygiene. Dr. Oshitani, who is who created cluster approach, he said, Europe and the United States didn't just look at trees, not the woods. To me, cluster approach is more on focusing on the trees rather than woods, but he said that was not the intention. The other people said that cluster control approach and 3 Cs identify the risky environment, closed, crowded, and contact. 3 Cs was the invasion of Japan, and peer pressure, and the balls and the masks. To me, these are quite anecdotal and not necessarily based on the hard science or facts. So we may need to do more detailed data-driven analysis of these factors. But the problem with the Japanese approach is that we did have a huge hospital transmission and, hospital nursing home transmission. So this is the latest paper published in the CDC document. Among the 61 clusters, and more than half of them are hospital and nursing care setting. And many of the originator of the cluster are asymptomatic, young asymptomatic people. So unless we tackle this, it's very difficult to contain the transmission. So the current cluster control approach will definitely miss these people. And this is a famous Age General Hospital instance. And as you can see, once this virus gets into the hospital or nursing home, the mortality rate is substantially high. In this case, 20%. So it becomes a killer virus. And here's the reported number versus the reality. So this is the slide written in Japanese, but basically this is the comment from the vice chair of the expert panel. They said, Japan has employed CT. As you know, the Japanese hospital have more CT than any other country in the world. So they said, because for severe pneumonia cases, they employ CT, so they will not miss any COVID. Although Japan has not implemented PCR testing, there is a system such as CT to confirm all the cases. So therefore, they think that the reported number and testing cases reflect the true value. But in Japan, there are more than 100,000 pneumonia cases every year. And how can you test and identify all COVID? And as you know, COVID and the variety of clinical symptoms of COVID, it's not just pneumonia and stroke and many other potentially deadly conditions could be associated with COVID. On top of that, nursing homes or chronic care beds in the hospital, very few people are tested. So there are recent series of antibody serological surveys, and there was an attempt to estimate excess mortality. Excess mortality is the comparison of this year's mortality versus previous year's average, so that because of the external shock like COVID would have an impact or not by comparing these two mortality measures. So on your left-hand side, this is a company called a big company, IT company SoftBank. They did an antibody survey among their employees. So on average, the seropositive was 0.4%, and among their general employer, 0.2%. It's very low. So my concern is that Japan is very, very susceptible to the next pandemic, next COVID infection, second wave. And Nikkei newspaper, I helped them, but they did their own excess mortality estimation. In Tokyo, there was thousands of excess mortality. I can't say that this is all due to COVID, but it's a mixture of direct COVID versus and also indirect consequences COVID. So right now in Tokyo, there was 300 deaths, 311. But from this, there seems to be 10 times higher deaths in Tokyo, not according to the excess mortality. Obviously, all of them are not necessarily due to COVID, but we are missing many deaths. And also from this antibody survey, the cases, even we applied very low test positive antibodies, so the prevalence of 0.23%. We still see that there seems to be a 20 times higher number of cases in Tokyo. Even if these numbers compared to the Europe and the United States, the cases and deaths are not that high, but still, my message is that there are many missing undetected cases and deaths. And on top of that, case fatality rate is around 1%, which is consistent with previous published data. So there are a bunch of speculation. Japanese is very strong to COVID infection. They have a previous infection to another coronavirus. So many speculation. But from this case fatality rate, that kind of claim is no longer applicable. And as you say, as you can see, the number of tests is still very low in Tokyo. This is a public one, so it's not including all the private sector cases. But even now, they are just doing hundreds of tests per day, only 100 from the public sector. Of course, they have more thousands of testing by the private facility, but this tells you something. So I will stop in the next couple of slides. And so one of the biggest studies Japan is trying to do is to have a social distancing measure. And my question is, can we really engage in social economic activities by just taking social distancing, avoiding 3 C's, close contact or environment? So surprisingly, Japanese government guideline about event like live house, concert, audience remains silent. The artists wear these face masks, and taking 2 meters distance each other, and always clean hands with sanitizer after shaking hands. Does that really work? So, of course, in theory, if you don't know who is being infected, you have taken distance. But does that make the society work? On the totally opposite approach is massive increase in testing, tracing, and isolation strategy. These are becoming mainstream these days. In the US, Harvard University, Rockefeller Foundation are proposing very, very large number of tests per day. But that's the only way to make the society work without continuing to take very stringent social distancing. UK as well. So quite a few are now advocate universal regular PCR testing. I did in the Bunshi online long time ago. And then surprisingly, Paul Roma, who is a Nobel laureate, very famous economist at the New York University, he also suggested exactly the same approach. Now SoftBank, Mr. Song is advocating we have to do the PCR test by using saliva, it's easier, and of course supplement the antibody test for everyone so that we can make the society work. So to summarize what has made a difference so far, bunch of speculation, bunch of factors need to be considered. I cannot attribute to a single factor, but I think prompt of response would be a key factor. Japanese response, I think there seems to be a clear timing lesson right after the Olympic decision, and people behave very well. But we need to carefully look at the data, how this relatively mild lockdown measure really worked as a real lockdown on the ground. So I need to look at how this worked on the data. But at the same time, there seems to be significantly underestimated case and deaths. The future direction, I think, massive social distancing, or there was a very strange message that the 80% reduction of the contact from the people when there was a state of emergency declaration. But I don't think the society can continue sustain or be sustainable. So I think from the top down, across the board approach to personalized risk assessment would be crucial, because the risk of COVID varies substantially, not only because of your risk by age and ethnicity or obesity or other personal risks, but also social environment, where you work, how you engage with the people, and of course other social determinants and inequality and social setup. So depending on the type of people and how you engage with the community or network, and who will bridge this network, unless we understand these associated risks, top down across the board risk mitigation will definitely damage the society. So we need to expand the test and other measures. Thank you very much.
Thank you.
Dear Professor Shibuya, thank you very much for your rich and original analysis, allowing us to document ourselves better on the ongoing health situation in Japan in comparative perspective. I will now invite Professor Lohse to start his talk. Professor Lohse, the floor is yours.
Sorry. You need to start your microphone, please.
Okay, can you hear me now?
Yes, great.
Very good. Can you go to the next slide, please? That was just the introduction. It is good that we have this discussion, because I think we will have some agreement and also some disagreement on what is important and what we should look at in this pandemic and in the future. I absolutely agree that testing capacity and actually applying tests is important. And I was really impressed by the low numbers of tests in Tokyo. Our hospital alone does 500 tests every day. So yes, we have a very high testing rate in Germany and have had that from early on, which has clearly changed the picture and also changed the strategy. What I'm showing you here are the official numbers, the official confirmed cases, and I believe the very wide testing strategy that we have in Germany, there are probably very few clinically diseased undetected cases, but of course we know that only a small proportion of infected patients actually develop clinical disease. So we all believe, and we have some regional studies showing that the infection rate is probably 10 times higher, even in Germany with a high testing capacity than the official case load. And that is why we believe the death rate here of 4.7% across the country is probably also a 10 times or at least 10 times overestimate. Another important point to consider right from the beginning is that not every person who died with a positive test actually died of this disease. Now, every country has a different definition of a COVID-19 death, and that's one reason why it's difficult to compare rates between the various countries. In Germany, the definition was anybody who died with a positive virus test was considered a COVID-19 test. But in fact, our hospital was leading the post-mortem analysis of patients who died with COVID-19 disease. And we could show that at least 20% of those COVID-19 deaths were not due to the virus, but due to unrelated disease. In fact, we've had a very severe outbreak on a leukemia ward and had patients dying from leukemia rather than the virus, but still had high virus rates. So if you could go to the next slide, you see the infections time course in Germany. In blue, the onset of symptoms, and in yellow, the date of reporting. And reporting, as I will address in a minute, is a little bit complex in Germany, and there's always a certain delay in reporting. We have a national institute, but that doesn't actually get the reports directly, but gets them indirectly. You see this fairly rapid rise at the beginning of March, or really middle of March, largely imported cases from northern Italy, because some regions in Germany had skiing holidays, and they brought home not only a nice suntan, but also virus. But as you can see on the next slide, the reproduction rate in Germany had a curve that really requires closer analysis, and that I think partly contradicts my previous speakers on the role of lockdown, because as you can see, we have the maximum reproduction rate already on the 10th of March, maybe 11th of March. And as you will see on the next slide, the various measures that were undertaken. Can we just have the next slide already? No, go back one, the one with the red arrow. Here you can see that the lockdown took place around the 15th, 16th, 17th of March, because Germany is a federal state, and because lockdown measures are decisions by the provinces, the Länder. Lockdown wasn't at the same time everywhere, but it was just a spread of a few days. You can see that the reproduction rate dropped dramatically well before the lockdown. On the other hand, of course, you can say, why didn't we do it earlier? We had the warnings, we had the reports from Italy, and maybe we could have even reduced the number further with more strict measures. But you can also argue, if you look at this curve, was the lockdown really necessary? And was it necessary in the way it was done? I think there's plenty of space for discussion, and hopefully we will have some time for that. But I think this is a very, very impressive curve. It may have been that change in behavior, washing hands, sneezing not into your hand, and social distancing appeals by the National Institute already changed some of this dynamic, but it may also be a seasonal effect. Could we then go to the next slide, please? Another point I would like to draw your attention to in a few slides is actually the age distribution. And I think that is a very, very important point when we are looking at numbers, because we always report numbers or get numbers reported as if every infected case was equal. And we only look at reproduction rates by total numbers. But we don't really look at age groups. There's two reasons why we should look at age groups more closely. The case fatality depends dramatically on the age, but also the infection rates. So these are the number of positive cases per population, not mortality. And if you look at this curve, it doesn't really make sense epidemiologically. It's the younger people that mix more frequently. And of course, even though we also have an aging society in Germany, not quite as much as in Japan, but quite similarly, of course, we have a far lower proportion. So here's the number of cases per population. So that is already taking account of the distribution, of the age distribution. And you can see that the disease rate is much, much higher in the higher age population. And this is not only because these are nursing home outbreaks. And what is most notable is that you have this very low rate in children. That's detection of virus rate. This is not clinical disease rate. And as mentioned before, Germany had a very wide testing strategy. Can we go to the next slide? Then you see the case fatality rate, the number of deaths. This is actually not the case fatality rate, but this is the total number of deaths. So it's not normalized for the population number. And you can see that mortality only starts to be detectable from 50 years onwards, becomes relevant from 60 years onwards. You can see also the quite notable sex difference, which is only that notable in the age group up to 80, and then changes. Why does it change? Because we just have more elderly women. This is not a per population rate, but it's a total death rate. So in the group above 90, there are more women who die from COVID-19 than more men, but there are far more women above 90 than there are men. But this very remarkable death rate. And it's very important to really realize that more or less nobody below 40 died. There are just a few cases. Most of them were very severe leukemia or patients with other diseases. So this is very important for the question of how society, I think, should react in the future. If you can go to the next slide. Christian Drosten, the virologist who was the discoverer of SARS virus and was also one of the first to develop a PCR testing for this virus, takes a different position from the one that I take about the risk that is in children and young people. And this is his very much debated paper, still not published, still only on his own online server, but very much debate on the amount of virus that you find in the throat of infected people, according to age group. Now, there are various biases in this graph because he just took, or his group just took the test that in the Berlin Charité hospital was sent to his lab for routine testing. So there's already the bias who is being tested. Then you see the number of viruses. The higher the point is, the more virus you have. And the number of dots in each of this graph and the size of this picture is the number of infected people. And as you can see, yes, children 0 to 9 years, 10 to 20 years, young youth people do have virus, which is obvious. If they are sick, they have virus. And they only get tested if they are sick or if they have had close contact with somebody else. You can also see that they have less virus than the others, but you can most impressively see that there are far more people in the older age group. So children and young people are very rarely infected. If they are infected, they have lower viral loads. And probably the most important point, we are increasingly learning that this virus is spread not by every infected person, but if few people infect a lot of other people, the so-called super spreaders. And those are probably the ones who have more than 10 virus load in the throat. That's just the upper block on this graph. And that really starts from 20 years onwards. There you have people with very high viral load, and those are probably the ones we have to watch out for. So this very much argues, and there I think we have agreement that we have to have individualized strategies if we want to prevent spreading of the virus so far. Can we go to the next graph, please? So how is healthcare in Germany organized? It's organized on a federal basis, as I said, the Länder, and it's even organized more decentralized. We have the regional health offices, what we call in Germany Gesundheitsamt, and they are responsible both for data collection, case ascertainment, and for the local regulations, whether we close schools and so on. That can be overruled by the Länder, by the provinces, but in normal routine situation, it is just the local Gesundheitsamt. And the National Center of Disease Control, the Robert Koch Institute, is the advisor to the national government, and it's of course in charge of national guidelines. But they only get their reports from the local health offices. Next slide, please. This regional organization has advantages and has disadvantages. One advantage is that it allows a flexibility in the response, and I will demonstrate in a minute how regional differences are important. And of course, there's much better knowledge of local risk and local capabilities, how many hospitals are in that region, how is the social structure of that area, etc. The disadvantages, of course, next slide, first an advantage here, the regional distribution of the number of cases, the number and the cumulative incidence, and the darker blue, the higher are the number of cases. And you can see that we have had regional hotspots. They're mostly in the south of Germany. This is related to the import of the infection from Italy, the northern Italy, and the skiing holidays, but there's also a lot of trade with northern Italy. Then you see in the very west a small dark blue area that is import from France, that had a fairly high region. And then Hamburg, which is in the north, is also darker blue. That's a peculiar reason, which is probably why you invited me also to talk. Hamburg is also a hotspot because we have a special skiing holiday in Hamburg, and actually Hamburg, even though it's far away from the mountains, has the highest rate of skiing people in the whole country. So we've had a lot of imported infection in that population. So at the same time, you see there are rather wide regions of very few cases. And the question is, did they really need a lockdown? And that's what we have now learned, that reacting regionally is now, of course, much more appropriate. Next slide, please. So yes, advantages are flexibility in the response, better knowledge of local risk, and a direct communication between the healthcare providers and the regulators. So it's much easier to react quickly to a change in the situation. Next slide, please. Disadvantage is that we have a reporting delay, and you already mentioned that in Japan, that on Sunday and Mondays you have fewer cases. This is very pronounced in Germany, that the National Institute always reported on Monday a drop in cases and on Tuesday an increase, because over the weekend the local offices often didn't report. Some of the local offices at the beginning were understaffed and didn't actually have staff at the weekend. So we've had this very delay, and it's very old-fashioned. They still send a fax to the National Institute, and then these cases have to be reported. And this regional organization also leads to an incoherence in epidemiological data collection. For example, we don't have national mortality figures that are really reliable, and they're always highly delayed. And the local offices often have limited expertise, not only because of understaffing, but also because you don't have an expert, of course, in every region. And you have the risk of local political influence. If a businessman has a good relation to the mayor, who is the head of also the local health authorities are responsible for that, that may have a negative influence. And as I mentioned, no reliable national morbidity and mortality statistics. Next slide, please. A very important aspect in Germany are intensive care capacities. And if Germany is praised a lot, it is praised for something that was also a mistake in the past. Germany has far too many intensive care beds, which makes our health system extremely expensive. And we have a payment system by which a hospital gets more money the longer a patient is on a ventilator. That's why we have a lot of ventilator places in Germany. But in this situation, this was an enormous advantage. We had an enormous ICU capacities. If you compare the United Kingdom, they have 5,000 intensive care beds. With Germany, they have 25,000 intensive care, which was just a little bit 20% higher population. So we have almost 5 times higher intensive care capacity. What is shown in this graph is the free capacity that we have had. And all through the crisis, we have had, because we expanded the already very high capacity in preparation of the crisis, we have had 12,000 unused intensive care beds. So we could have easily dealt with far more cases than we actually had to deal with. So that was a strength that has grown from a weakness, a strength in this situation for the German response to this. Next slide, please. I think a very important underlying features in the global response and the regional responses is what is the appropriate fearfulness, and the German expression Angst, which is used in English as well, is a very good expression to describe this response, which was very, very strong also in the media. So what's appropriate fearfulness and what's appropriate carefulness? One important problem in creating, I think, exaggerated fearfulness was death numbers reported. Every day on national news, everybody said the number of deaths has increased. Well, there's no way that the number of deaths can decrease. You can only add further deaths, of course. But we never got reports of the daily number of deaths, and that the daily number of deaths has actually very quickly then decreased again. It's only late in the pandemic that this has now become more usual, that the rate per day is being reported. One important other aspect is, why was everything focused just on one disease? And we just had that in the previous talk, the report of how many deaths could have been prevented by an earlier lockdown. And the higher mortality rates in Tokyo, but we don't know whether these are COVID-related mortality. We all know that all across, really at least Western countries, emergency admissions were down by 40% in emergency departments. So people with myocardial infarction, stroke, and so on didn't get hospital care, and the mortality may be related to the pandemic, but indirectly, not because of COVID-19 death, but because of lower health care for people with severe cardiovascular diseases. And the same is, of course, true with the economic consequences leading to hunger worldwide and so on. So very few epidemiologists, I would say really no epidemiologists, have really addressed the fear of total mortality resulting from not just the infection, but the response to the infection. So we haven't really been discussing the longer term consequences, and we haven't really been thinking from the end. People, at least in Germany, have very much said, well, we will do a lockdown until we have a vaccine. When we have a vaccine, we open the schools again. But a vaccine against this virus will be very, very complicated. will probably be delayed. And who actually should get the vaccine? The young people who are not in danger of death, or the elderly people who we know very well from influenza and other infections do not respond very well to vaccines. So a vaccine is really highly questionable and complex. That will be a long and complicated discussion and process in the coming years. I think that is the end of the slides. No, we have two more. I very early on at the end of March already propagated that we should open kindergartens and primary school, partly because of this vaccine discussion. The children are not really in danger. The children are probably not really spreader, at least the young children are not spreader. But at the same time, I appeal we should have had a much stronger protective response for the in danger population, old people home. Also in Germany, we didn't have enough masks for nursing homes, etc. So we should have protected the elder population more, but probably we should have allowed infections in the younger population so that we get at least some degree of herd immunity, which now with a very low infection rate like in Japan, we remain unprotected from the next wave. Next slide, please. So if we look at the positive and negatives together, we had a fairly low infection rate and low mortality rate. And of course, yes, with the high testing rate, we had a very good way of steering through the crisis. And we had a wonderful excess ICU capability, and no hospital was really at its complete limit. But we missed our chance to develop herd immunity safely by just allowing infections in the low risk group and protecting the high risk group, and thus remain in danger for future waves. We did not protect the vulnerable well enough, at least at the beginning of this crisis. And in fact, 20% of the death rate is actually in people with dementia. Like everywhere else, we have very high collateral damage in children, lack of education. All research activities were stopped across the country, and the economic consequences you all know. Thank you very much for your attention.
Thank you very much, Professor Ansgar. Sophie.
Yes. Thank you, dear Professor Lohse. We are grateful to your enlightening presentation, which proficiently completes Professor Shibuya's rigorous analysis. It decisively opens the door to comparative debates on the impact of COVID on national, but as you have noted too, it's very important subnational scales. So now I will invite Professor Paul-André Rosenthal to start his presentation.
Okay. Okay. What I'm going to do is compare the French data in time and space very quickly, and then introduce a sort of demographic analysis in order to control for the available mortality data, which for me are biased by many population parameters. Then I will relate my adjusted mortality data with public health data and explain my conclusions. So we can start, Barbara, with the first slide. Okay, so on the bottom, the colored lines are the daily mortality of in regular years in France from 2010 till 2019. And by comparison, you see here on the left a red curve, which is the coronavirus excess mortality. And on the right, you see this blue curve, which is the excess mortality caused by the Hong Kong flu in winter 1969-70. Here, the yellow one is the heat wave. So what you see here is the regular deaths. You have a few peaks which are caused either by exceptional flus or by heat waves. And then you have those two big mountains on the right and on the left, Hong Kong flu and coronavirus. And as you see, both of them have the same shape and height, and both account for about 30,000 deaths. And as you know now, population in France accounts for 68 million people. So you can move to the next slide.
Mm-hmm.
So the difference is, of course, that in 1969, little was done against the flu, except vaccination, which was no big success. So you can move to the big one. Whereas against the corona, you can move to the next slide. Okay. Okay, thank you. What happened in the beginning, that in March, is that hospital capacities were overwhelmed in the east of France. Some patients were transferred to Germany, actually. Medicine triage, war medicine triage was implemented, and some patients could not be treated by the hospitals. And in the Paris region, when the lockdown occurred exactly at the time where hospitals would have been overflowed by the flows of patients. So really lockdown occurred in France at the very last minute to avoid a hospital disaster in the Paris region, which is of course the most important one. So, and next slide, please. To compare now, next one. Yes, thank you. So to compare excess mortality in a few European countries, as you see on the bottom left, France belongs to the range of countries like Spain, Belgium, etc., and the UK, where excess mortality has been very significant. And as you see, many other European countries, excess mortality was limited as compared with previous years. So in the next slide, please. My work, my research has consisted in taking coronavirus mortality data in 24 countries that I followed during the first 30 days of the epidemics. And as a demographer, what I've done is controlling for the raw mortality rates, because I'm very struck by the fact that even though there is a very intensive and very stimulating research on mortality data, there is little reflection on the population parameters which play a structural role in the intensity of the epidemic. And if you think of epidemic phenomena, you have to control for population density, population distribution over the territory. It has to do with what Professor Shibuya said on the importance of big cities in Japan, for instance. You have to control for the intensity of internal and external mobility within the country and towards the country. And you have to control, of course, this is sometimes done, but not always, with the share of elderly people. So I've done all these controls, and I have, next slide, please, reconstructed. You see them on the next to last column, adjusted mortality rate. This adjusted mortality rate is not a mortality rate by itself. It's more of a reconstruction, an artifact to try to control for those population parameters. And here on the rank, you see that Japan appears as the least affected country, Germany at the 8th country, and France as the 11th country once you control for those mortality. Something I would like to stress is that if you take raw mortality and if you take my adjusted mortality rate, what's striking is the spread between the most efficient and the least efficient country. It varies from 1 to 400. And it's a very important thing, because if you are thinking of national statistical data, of course, it's very important to be very precise and arrive to the most precise data as possible. But if you think in terms of comparison, the spread is so high that you can afford to have some uncertainty variation around the figures. Next slide, please. Yes, thank you. So the result, if you take the adjusted mortality data, you see that there are three different blocks of countries which very clearly appear. First one with Japan and South Korea, with Germany and Scandinavia. I will not detail, but also Israel. You cannot see Israel, Greece, and Hungary. And then you have a block of countries with intermediate mortality, in which you find France and Netherlands and United Kingdom, among others. And then countries which are affected with very high mortality, including South Africa, USA, Switzerland, Spain, etc. So I have clearly three blocks of countries with very, very different rate of mortality. So next slide, please. And I've tried to relate this with some indicators of public health that you see, that you can see them. So health spending, number of hospital beds, quality of intensive care units, both for infection and for ischemic stroke, which is a very significant indicator. So it very much echoes Professor Loser's reflections on ICUs in Germany. And then intensity of testing and tracking, you both mentioned that. And also I use the Oxford Stringency Index, which is a statistical reconstruction of the intensity of reactive public measures in all the countries in the world. And I use this stringency index for day 1, day 10, and day 30. Next slide, please. Okay. Here you have the tables. Of course, I will not discuss them. What I would like to do is, I mean, you can see them. You can see that, for instance, but I cannot show them, unfortunately. You can see, for instance, how ischemic stroke data differentiate between block of countries. Block number 3, the data are not perfect because this indicator is not documented for, it's only documented for OECD country. So I will go to the conclusions right away. Comparative conclusions, and then some specific facts for France. General conclusion, I was very interested by both presentations before mine, because you have both pointed the importance of social science. Social science is very important for two things in the story. A, there are different ways to distribute responsibility against the epidemic, to distribute responsibility between central states, local authorities, including the Länder, for instance, in Germany, NGOs, and citizens. And with one extreme case, for instance, which is Sweden. Sweden has been a case which has been very much praised in France. French citizens envied Swedish citizens, but they are not aware that in Sweden, you have a law on infectious disease, which makes you personally responsible for transmitting the disease. And this law is extremely severe and has been very severely implemented, for instance, during the AIDS epidemic. So, and second reason, B, is that, as you both mentioned, behavior and expectation differ a lot between the population. And one of the consequences, and this very much echoes Professor Shibuya's comments, is that official compulsory lockdown is not necessarily a good indicator of what goes on in a country. You have countries have had light lockdown where population behaved as if there had been a much official lockdown. And I think it's a very important point. At this point can be documented with quantitative indicator. I have no time to show them. Two, second result, of course, the scale and quality of public health investment and infrastructure and quality of ICUs units have been central to fight to limit the epidemic. Third, at least 3 profiles and 3 national strategies have proven effective against mortality. One is having, and that's rather true for East Asia, like Japan, is having many hospital beds. And I think that's the reason why Japan could avoid making many tests. It's true that Japan is totally different as the other countries by the very low rate of testing. Second profile, and that Germany goes into it, is having a wide variety of very good indicators. like many hospital beds, testing capacities, quality of ICUs, etc. So Germany, Austria, Scandinavia have this characteristic, like decathlonian athletes who are very good in very different fields. The third profile, which includes Hungary, Israel, and Greece, is having a very severe and immediate lockdown even before the epidemic occurs in certain cases, and closing the borders, but also combined with strong responsiveness. And here again, I very much agree, I think it was Professor Shibuya, but also Professor Lohse, that the promptness to react is a central parameter in the fight against the epidemic. I have no time to give examples, unfortunately. Fourth conclusion, by contrast, France is very typical of a range of countries with intermediate adjusted mortality rates, which share joint characteristics. In these intermediary mortality rates, you find many wealthy countries like Portugal, like United Kingdom, like Netherlands, with a lighter health infrastructure than the previous ones. In those countries, preeminence of the welfare state and full benefit jobs allowed to privilege the protection of lives over preservation of the economy. So it allowed for a severe lockdown, a more severe lockdown than in Germany or Scandinavia and such. And third, in those countries, in those block of intermediate rate mortality countries, you have strong pressure from the public opinion, but with a contrasting demand between health protection and freedom of circulation and economic and social activity. And France is very typical for that. France is very typical for wealthy countries, but with many structural limits to fight against the epidemics. Not enough hospital beds to afford an overflow of patients. Very strong, small responsiveness because of a very strong bureaucracy and because of a very complex organization of health services, which happen to compete with the specific organization of the state itself. So this number of institutions and competition between institutions played a role for the very slow responsiveness of France. Then lack of preparedness, shortage of masks for citizens, but even for medical staff and for the professions in contact with customers and with patients. Shortage of tests, ideological public opinion opposition to tracing. I mean, there was no way asking people to implement tracing instruments, whereas French citizens use smartphone, but okay, that's it's an ideological position. And also very poor governmental communication in the beginning, which started by negating even making fun of the importance of the masks, which was not a very, very good idea. So as a result, France is very representative. It would be the case also for Switzerland, and also to some extent to Netherlands and to the UK. France was reduced to a constant juggling by authorities between those conflicting demands from populations, and with a very limited possibility to fight because of the lack of reserve of hospital beds. And the very interesting thing also is that the French communication of the French government was not even able to highlight actually the success, the relative success of its policy, in the sense that France, except in the East, has avoided mass medical triage in the hospitals, I think. And this was the strategy of the government, but the government could not say it that way because it was too limited a goal. And also the French government was not even able to communicate on one of its successful policies, which was to transfer patients from the regions which were overloaded with patients, like Paris region, towards the province, the provincial hospitals where there were largely enough beds to welcome them. So, okay, I finish. I'm sorry for the technical problems in the beginning.
Thank you very much, Professor Rosenthal. And now I would like to join everybody to start the cameras again. Thank you very much for three very exciting, thought-provoking and presentations that we learned a lot from. We see here we got so many questions, and we have very little time, but before I give it to Sophie to ask some of the questions from the audience, let me just start with one that's really pressing. I would like to know what you think, what the role of the media is in disseminating knowledge, these statistics. Are you satisfied with that? Because that also goes a long way with the behavior of the people in regards to, you know, agreeing to the lockdown regulations and mask wearing and so on. So who would like to go first, please? Yes, Professor Lose.
I already mentioned the media. I think the media was an extreme problem. In fact, very early on, I tried to give a more differential view of the danger of this virus and the likely development. And as a medical professional, I think I have quite good relations with science journalists. And the science journalists told me in the top press, the top journalists, we cannot publish these views because it's the editors and the political journalists who don't allow a critical view of new measures. It's just one view that is allowed, and that is, this is incredibly dangerous. So I think a lot of the overreaction and the inability to really have a productive discussion was this widespread, yes, panic, angst.
Mm-hmm. Okay, thank you. How was it in Japan?
Yeah, I'd like to echo which just the professor also mentioned. And obviously, media has a very important role to convey a very important message, but mostly they focus on the very short term and impact, particularly the PV or other sort of metrics. So they tend to focus on some sensational number, and instead of differentiating their story from the others, particularly TV media and net media, and a bunch of speculation and very heated debate about testing in Japan. Although in other countries, I don't think there is much of the issue on that. So I think this is one of the probably the most politicized pandemic in the history, and that was aggravated by the media and the fake news. So this kind of community focusing on the fact and a broader view would be quite valuable.
Thank you. And for France?
To be short, one, I would say that media communication was extremely stratified. I mean, from very high quality by elite newspapers to fake information, as Professor Shibuya said. And I would like to stress in this matter the role of social networks, which increased even this stratification. And two, in France, we were unlucky enough to have these medical physician who claimed to have a miracle recipe against the coronavirus, and all media focus. I mean, he's very good. You should hire him as a professor in a communication university. Is excellent for communication. He's going to make a good career now, I think, as such. And it was a disaster because he focused most of the attention for nothing, actually.
Thank you very much.
Could I add one point?
Sure.
I think the role of pictures was particularly important. I think all of us, at least in Germany, we were shown these refrigerator lorries in New York. I think I've seen about 100 times. And the report was that they didn't have capability to bury their dead. While in fact, that wasn't the problem, but official big ceremonies weren't allowed. So people opted for having the burial later and therefore needed these lorries. And in fact, in New York, everybody who needed intensive care bed could get an intensive care bed. But the pictures that were shown in Germany looked as if there weren't enough beds.
Yeah. Oh, thank you very much. That's
very interesting.
Yeah. Sophie.
Yes. Yes, I collected. So I first want to deeply thank all our listeners. We received a ludicrous amount of questions, very interesting questions, which I tried to synthesize. I will first ask an earlier question raised as a reaction to Professor Lowe's presentation, but which could be interesting to compare. One commenter wondered about the issue of reproduction rate, which was and remains very important in Germany. And he would like to know if a similar discussion is going on in other countries.
Yeah, in the
That's
case
not
of
for me to
Japan,
answer.
go ahead, sorry.
Yes.
Yeah. So in Japan, I think the R number, particularly effective reproduction number, is considered to be one of the key metrics. But the problem is that there is obviously a time lag between the timeliness of R number, because usually there is a distinction between the onset of the case and also reported case. So we have to, there is a time lag. So there is an effort to focus more on the timely reporting on some proxy of R number. But of course, also R number depends on the quality of data set. And as you can see from Japan's testing capacity, there is a change in the diagnostic criteria and change in the potential uptake of the test, there seems to be inconsistency over time. So there seems to be some of the problem in terms of input data, but that has been discussed.
But maybe the R number, in fact, in Germany wasn't really discussed at the time where it was really most relevant, which I showed in the slide. It only came up as a topic at the end of the spread of the virus. Previously, it was a not mentioned figure. But I agree, of course, the R number only makes sense if you have wide testing. And in addition, as I mentioned, R number does not relate to the risk of people who get infected, which I think needs to be addressed much more.
It's very interesting what you said, Professor Loza, because I think in France it arrived a little bit earlier, but it arrived when the government needed to impose the severe lockdown. So then there was a popularization of this indicator.
But in Germany, it did not arrive at that stage because it would have stopped the lockdown because it was already falling.
Yeah, yeah. Very interesting. Yeah.
Japan is the same. When it's a very post hoc assessment. And when the Japanese government implemented state of emergency declaration, obviously our number was declining. So as in the case of Germany. So it's very difficult to show the timely, real-time R number, first of all, technically. Secondly, it's very political in terms of showing the number at the right time or when to justify their own politics. So.
I think we have one more question, time for one more question, Sophia.
Yes, and I'm sorry for all the questions that won't be answered right now. Several, I will say, I dare say a cluster of questions were concerned with the respective merits of cluster testing strategies, like the one that Japan has recently chosen versus mass testings. Can we really speak of a successful cluster tracing strategy without mass testing? But on the other side, isn't it a waste of testing capacities to conduct mass testings, especially in places where the prevalence rate is very low? And also one important set of questions was based on your three converging conclusions. Can we say that most governments followed 40 strategies causing more damage than good? And finally, also, I saw several listeners questioning the meaning and realities behind the rising notion of second wave. So questions about the efficiency of testing strategies.
Yeah. So there are two schools. One is based on prior prevalence of cases and go for the high predictive value positive, so focusing on those severe cases, was the strategy Japan employed when the capacity was limited. So it worked at the beginning when the transmission was not spread and localized. And Japanese strategy seems to focus on severe pneumonia cases, then try to identify the contact and contain. But there is obviously a growing number of evidence that asymptomatic, particularly pre-symptomatic cases, are also a problem. So the usual cluster approach, the original approach employed by Japan, will definitely miss that portion. Particularly, there was growing number of hospital and nursing care transmission due to asymptomatic or pre-symptomatic cases. So there are two issues. One is focusing on very high predictive value positive cases so that you can contain effectively. But the purpose to contain the transmission is a different story, because that is obvious at the border control, because you need to test everyone. Without knowing, of course, you need to understand the prior probability of infection depending on where you come from. But at the border control, you get tested regardless of the potential probability of infection. So control the infection and of course thinking about predictive value positive with prior probability. The goal is the same, to contain and to reduce the morbidity and mortality. But the approach seems the same and the different. So even the cluster approach is changing. They change the criteria to include asymptomatic contact for testing. So more or less we are kind of converging to understand the importance of pre-symptomatic cases. Unless we tackle it, it's very difficult to contain the transmission.
We have still time for 2 comments. I think in all testing strategies, you have the problem of the predictive value. If you test too many healthy people, you get too many false positive tests. So mass testing, if you have a low incidence, is not very wise. That I think also applies to CT, and CT actually has radiation. That's why we did it very early on and then stopped CT completely. We don't do any CTs anymore unless we have a very strong clinical indication, even though we are only second to Japan with the number of CT scans, so we could do it. But,
I agree. So unless the exposure and the CT could not be a good supplemental study.
And what I would like to stress is that you have to test high-risk areas.
Exactly.
So we now have a strategy. We had severe hospital outbreaks, and now we're testing every new inpatient. And even though we need to test 500 to detect one positive one, that makes sense, because an outbreak in the hospital is really a problem.
Yeah, so that's also the
kind of testing that makes sense.
Exactly. I fully agree. So we have to test everyone, a patient or has worked at a hospital, nursing home, but potentially at school or high-risk environment. So that's a priority. So even asymptomatic cases, everyone needs to get tested.
Okay. Professor Rosenthal, as a last word.
Maybe I could shift directly to the second question, because if it's fine with you.
Yes, it is.
As for the question on government's efficiency, I think first, and it has also to do with your question on the media, one should not consider that it's possible to evaluate government's reaction between taking into account the existing health infrastructure just before the epidemic. I mean, and this is always forgotten. Government's reaction has to be evaluated according to this initial preliminary factor. Then, so from that standpoint, I'm not sure that it was so disastrous. It was far from perfect, but it was not so disastrous. So different ways to fail, I mean, to have bad strategies, was either to react too late, as was shown by the other two speakers, either to react too far quick enough, which was the case of many countries in Western Europe. Spain, Belgium, France reacted too late. The second way to be unsuccessful was to stick to the notion of herd immunity, which was very negative for the UK and for Netherlands. Netherlands could have done much better because it has very good health infrastructure, actually. And the third way is to be prepared, to have a very nice preparedness to pandemic, but to stick to it. It was a problem with Switzerland. Switzerland was extremely well prepared, but not to the right virus. And it took time to respond, to react to that. And I think what happens today in Sweden is about the same. Sweden, they feel very proud of their model, but it worked in the beginning, but now it's showing its limits, and the Swedes are a little bit too late, in my view, to react. Okay, and then there will be the question on second wave.
Any last words, Professor?
On second wave, I will ask the question to my two colleagues, actually. As an historian, I know that epidemiological models incorporate still echoes of the 1918 pandemics, which went into 3 waves, and the second one was the most lethal by far. So my question is, when we think of the second wave, do we think historically, I mean, because we have the memory of this pandemic, or do we think in terms of virological science today, which claims that, for instance, because of potential mutations of the virus, there might well be a second wave after during the autumn? So is it rather a historical reflection based on precedents, or is it a medical anticipation, expectation?
Yeah.
I think we really don't know. Even as virologists and immunologists, infectious disease people, we really don't know. There are too many variables, and we've seen SARS disappear very quickly, MERS disappear quite quickly, and we were surprised that this virus spread so vastly across the globe. But now it's disappearing with and without lockdown in different countries, and only spreading in the southern hemisphere, really. And that may be the climate factors and viral mutations. Generally, viruses become less dangerous as time passes because it's not in the interest of the virus to kill the host. It spreads best if it doesn't really kill. So it's likely that this virus, with time passing, will actually become less dangerous. But whether that actually will have happened by next autumn, we don't know. So we need to be prepared for a second wave, even though there is clearly a possibility that it will be less harmful.
Yeah, I agree. In the long run, maybe 5 or 10 years later, the virus become like a seasonal flu. But until then, we have to get prepared because this is very tricky virus with a relatively high case fatality compared to seasonal flu. And if it happens in a massive scale, we have a disaster. So we need to get prepared. But otherwise, there are a bunch of reasons to believe that there'll be a second wave, not just historical, but also biological. And of course, if you look at the current status of pandemic.
Well, unfortunately, we have run out of time, but it is to me, and I'm speaking also for Sophie, to thank the 3 of you for these very insightful, very thought-provoking presentations. I wish we'd have another hour to go into all these many questions that we've gotten. Sophie and I have lots of pressing questions, but we'll have to leave it here at that. We learned, of course, we know it's a long road ahead, a long fight to go with. As you said, it's a very unknown road. We don't know what's coming, how it's developing. And we learned from you that as good as statistics are, of course, they are improvable. From what I learned, it seems like particular mortality rates and could be improved, and also what the media does or does not do, or how it portrays things, could be better in order to, since this is still a long road, to inform citizens all over the world adequately. To our audience, thank you very much for listening. Thank you very much for participating. We apologize that we couldn't get into all your questions. And down below on your YouTube channel, you see links to the Maison Franco-Japonaise and to the German Institute for Japanese Studies, the DIJ, if you are interested in seeing further events that will be, of course, now hosting much more so on YouTube. So with that, thank you very much, and see you next time.